Welcome, everyone. Thank you for joining. This webinar is part of RUNX1 Research Program's Medical Education Webinar Series. And today our webinar is entitled Revealing the Genetic Underpinnings of Cytopenias, Navigating the Path to Genetic Testing. I'm Katrine Erickson. I'm the Executive Director of the RUNX1 Research Program, and I will be your host for this webinar today. Some of you on the call may be familiar with who we are, but some of you may not know about RRP. So I'd like to just take a moment to share who we are. We're a nonprofit organization who is dedicated to supporting patients with RUNX1 familial platelet disorder. And unfortunately, this disease confers a 35 to 50% lifetime risk of developing a hematologic malignancy, predominantly AML, followed by MDS. This disease is caused by germline RUNX1 mutations. It causes mild thrombocytopenia and reduced platelet function. And more recently, we've learned that it also is associated with inflammatory conditions, including both allergic conditions and autoimmune disorders. Our mission at RRP is to improve the quality of life and prevent blood cancers in RUNX1 FPD. And we do this through more than just medical education. We do this through funding basic translational and clinical research. And we build or aim to build an engaged and supportive community with patients, scientists, and clinicians coming together. And we spend a lot of effort raising awareness, not only through medical communities, but also raising awareness in the public. So you may be wondering, why are we supporting a webinar series on cytopenias in adults? And that's really because one of the most common ways in which our families are diagnosed is at the time of a hematologic malignancy. And we want that to change. We want individuals to be diagnosed before they develop a malignancy so that we really can achieve our goal of intercepting or even preventing blood cancers in the future. And so we need to identify at-risk patients. So we really think it's paramount for classical hematologists and genetic counselors and other providers to hone their skills on identifying when and in whom to order genetic testing so that individuals with germline conditions, including RUNX1 FPD, are diagnosed accurately and quickly before any life-threatening events occur. You'll learn from our speakers and our panelists today that uncovering a germline condition can ultimately impact treatment options, treatment outcomes, and in some cases, really the care of family members as well. So with that, I'd like to introduce our expert presenter today, Dr. Ley Tung. Dr. Tung is a medical geneticist and assistant professor at the University of Iowa, whose research is really focused on discovering genetic causes of bone marrow failure and hereditary hematologic malignancies. And as I've gotten to know her over the past year and a half now, I think, I really appreciated that she has an incredible passion for the work that she does, and that she's equally passionate about raising awareness on when and how to use genetic testing in your clinical practice. After her presentation, we'll host about a half-hour Q&A discussion, not only with Dr. Tung, but she'll be joined by Dr. Sioban Keel from the University of Washington and Dr. Ilene Weitz from the University of Southern California. Okay, so without further ado, I will turn it over to Dr. Tung to give her presentation, and then we'll have a discussion.
Thank you for that wonderful introduction. I'm going to be talking about revealing the genetic underpinnings of cytopenias, navigating the path to genetic testing. So just as an overview of the different topics we will cover today would be 1, challenges in the workup of an adult patient with cytopenia, recommended best practices for diagnosis of adults with cytopenias. We will talk about 3 clinical cases to highlight the complexities seen in the clinic and some of the take-home messages. And finally, there will be a panel discussion at the end. I do not have any financial disclosures to declare. So trying to kind of work through an adult with cytopenias can be quite challenging. One, A comprehensive personal and family history is hard to complete, especially in a very busy hematology clinic. Most of us do not really have the time to even get a proper 3-generation pedigree. On top of that, there is also the issue of fragmented clinical care, where patients can be seen at a variety of clinical settings, either in the PCP clinic versus a community center versus an academic center. And because they are seen at different locations, sometimes it makes it hard to track and even trend their CPC counts or their complete blood counts, because every institution uses a different electronic health system and they are not always compatible. Finally, there's also the lack of education amongst healthcare providers, physicians, nurses, APP regarding rare genetic disorders that can sometimes present in adulthood with cytopenias. Last of all, there's also a lack of standardized guidelines for what's the recommendation for germline genetic testing in adults with cytopenias. Now, all this makes it very difficult to navigate even the financial aspects of trying to get germline genetic testing, because first of all, insurance is less likely to cover germline genetic testing in adults, with the assumption that a constitutional disorder would have presented much earlier within early childhood, or even in the pediatric setting versus in young adulthood or even later in life. Finally, there's also limited research funding for non-malignant disorders. So what are some of the best practices that we can recommend for diagnosing and managing adult cytopenias? One is really to consider if an underlying genetic etiology is possible in every adult presenting with cytopenias. I think if you start with a broad differential diagnosis at the start, you're less likely to have tunnel vision and kind of hone in to a specific diagnosis too early in that diagnostic odyssey. Second, personal and family histories are really essential. A lot of times in the adult clinic, we don't ask a detailed personal, even family history, unless the patient feels very strongly about it and asks the provider if this other family history may be relevant to the cytopenias, and that's generally how we tend to probe a little bit more, but only if the patient brings up any relevant family history that they are aware of. Third, we would also want to monitor and trend complete blood counts over time. Once CBC is kind of just a snapshot in time, but the trend gives us an idea of what's happening with the different cytopenias that this patient has. Is it static? Is it worsening? Is it improving? So that gives us a general idea of what the potential differentials might be. And to always consider early ancillary testing, and we'll talk about this in the clinical cases later on, especially during the diagnostic phase. One other thing to keep in mind is what is the difference between somatic and germline genetic testing? And some of the cases that we'll talk about today will highlight the differences and the challenges in a patient with blood disorder. And finally, remember the impact on this test that can result in a different interpretation of the final result if it's in the post-transplant setting. So these are some of the considerations for managing adults with cytopenias. So we will go straight into the case studies right now. So the first patient is actually a 36-year-old male with learning difficulties and left sensory neural hearing loss. He was referred for abnormal blood count way back in January of 2012. Extensive workup revealed a normochromic macrocytic anemia with mild thrombocytopenia. He, however, was lost to follow-up and represented 4 years later with worsening thrombocytopenia during a screen as a potential liver donor for his mom, who had rapidly progressing cryptogenic liver cirrhosis. Now, if you look at the trend of his blood count, you can see that there's an obvious decrease in the total white blood count, the neutrophil count, hemoglobin, as well as the platelets. Some of this tests were done in the earlier phases of his diagnostic odyssey and were generally unremarkable. So he had a bone marrow examination which showed marked trilineage hypocellularity without any histological evidence of blast infiltrate. And he had a normal karyotype, which was 46XY. He had a chromosomal breakage test, which was negative, and a flow cytometry for paroxysmal nocturnal hemoglobinuria, which was also negative. We performed an ultrasound abdomen, which showed a slightly nodular liver surface with evidence of cirrhosis with splenomegaly, and this was concerning given his mom's history. He had an MRI brain, which showed an empty cellular and diffuse cerebral and cerebellar atrophy. We finally sent a targeted genetic panel for him for an inherited bone marrow failure syndrome, given his history of liver cirrhosis in his mom, as well as cytopenias in him, and as well as his younger brother, which revealed a hemizygous splice site variant of uncertain significance in DKC1, which is the gene that causes dyskeratosis congenita. When you look at the family pedigree, we quickly discovered that he had a younger brother who also had macrocytosis and mild thrombocytopenia around his late 20s. What was interesting was both the proband and his brother, as well as their mom, was seen in the same hematology clinic by 3 different providers over 3 different time points, and no one had made the connection that these 3 individuals were actually related. It was until we started doing more workup for the proband 2-1 that we pieced the family history together and found how these individuals were related, and this kind of generated a more cohesive history for us. Now, if you look at the timeline of the progression in terms of 3 different individuals within the same family, you can see that the proband really had some learning difficulties at the start with right sensory neural hearing loss quite early on in life, but started having mild thrombocytopenia in his late 20s, which is the similar trend that his younger brother has as well. We don't have any earlier history for his mom, but she presented at the age of 60 with thrombocytopenia, which was found to be secondary to her liver cirrhosis. Now, his trajectory was as such that his thrombocytopenia deteriorated quite quickly and progressed to aplastic anemia, and we also incidentally found liver cirrhosis as part of his workup. With this variant of uncertain significance in DKC1, he was actually advised to be started on danazol to treat him as a presumptive telomere biology disorder patient. And he was also referred to the bone marrow transplant team, who felt that his aplastic anemia was not severe enough yet to warrant a transplant at this stage. Now, as part of the workup, we wanted to try and send telomere length measurements for him, but because this patient was residing outside of the United States, that was not a test that was logistically easy to send. So we did a quantitative PCR instead for him in a research lab, and it just shows that both he and his brother have shortened telomere lengths. Now, this is not the gold standard. We would recommend to use a flow fish for telomere length measurements. There are only a limited number of labs worldwide that does this. Johns Hopkins is one of them, and Repeat Diagnostics in Canada is the other one. I believe there are probably 2 newer labs, one in Germany and one in Australia, that may be performing this test on a clinical grade setting right now. So take-home message for this patient really was a detailed personal history is important, and we really would be asking about birth history, developmental milestones, any learning difficulties, any other congenital anomalies that may not have been mentioned because they may have been corrected either surgically or otherwise in the early childhood. And if you're seeing them in their mid-30s, that might not be a history that they would volunteer, because it's such a distant history that they may not even be aware of it. Second, A three-generational family history is also very important, and we would hone in on anyone with birth defects, recurrent pregnancy losses, hematological disorders, and other solid tumors in other family members. Third, we would want to have a complete blood count and to trend it over time with close follow-up, especially in the early diagnostic phase. Fourth, early ancillary tests, and by this we mean flow cytometry for PNH clones, flow fish for telomere length measurements, and chromosomal breakage analysis will help to guide the appropriate genetic test or panel to send. Finally, early referral to medical genetics to exclude an underlying inheritable bone marrow failure syndrome would be useful as well. The second patient was a 49-year-old male with a chronic history of thrombocytopenia since the age of 25. He was originally diagnosed with immune thrombocytopenia purpura at that time. However, he progressed to pancytopenia at the age of 37 and was then diagnosed with aplastic anemia. Fast forward about 9 years down the road, as his pancytopenia was not improving, he was finally diagnosed with myelodysplastic syndrome at the age of 46 years old. As part of his pre-transplant workup by the adult bone marrow transplant team, he was found to have idiopathic pulmonary fibrosis. At this stage, the question was, does this gentleman have underlying telomere biology disorder given the presentation that he has over the period of time and the final diagnosis of idiopathic pulmonary fibrosis as part of his pre-transplant workup. Again, if you look at his clinical course, when we went back to ask him specific history, he did say that he had premature graying of the hairs since his teens. And then in his mid-20s, he was diagnosed with thrombocytopenia, been kind of stable over the years without any requirements for treatment. But when he was about 38, he had a bone marrow biopsy when he had a drop in his blood counts and was diagnosed with presumptive aplastic anemia. He was started by his local hematologist on cyclosporine. Counts did not recover, and he still was relatively transfusion dependent. He had a second bone marrow biopsy, and at this time was diagnosed with myelodysplastic syndrome and switched to a hypometallating agent with azacitidine, but still requiring regular platelet and red cell transfusions. As I mentioned, as part of his pre-transplant workup, he was also then diagnosed with idiopathic pulmonary fibrosis without any risk factors. He was a non-smoker. He worked as a truck driver, so possibly some occupational exposures, but nothing specific. And then we elected to send off his telomere lengths as well as a next generation sequencing panel for him at this point. Now, this was the trend of his bone marrow exam over the decade or so that he's been seeing his local hematologist. So his original bone marrow in 2010 just showed a hypoplastic marrow with a normal karyotype and normal fish. Now, 10 years down the road, he had a normal cellular marrow, but then he had trisomy 1 with this derivative 114 and an atypical break apart rearrangement on the 5' end of the MECOM gene. About a year later, as his counts were not improving, he was then shown to have now hypoplastic marrow with similar karyotype findings, but now had 2 clones which has acquired a trisomy 8. The fish changes were still static at this time, no changes there. But the question really here is how much of the cytogenetic anomalies that we're seeing now could be representative of a treatment-related change versus secondary to his underlying predisposition to MDS or even AML. So this is an example of telomere length using a flow fish measurement. And as you can see, both in his lymphocytes and granulocytes, they are both less than the first percentile. So that was concerning at this stage. Here, I just want to highlight that he had 2 genetic testing done, one on the peripheral blood, which was done earlier, and the second one was done on the cultured skin fibroblasts, because when we look back and saw that he had all these cytogenetic changes in his bone marrow, the concern was any genetic changes in the peripheral blood would be a reflection of a somatic variant rather than a germline. And what you will quickly realize is between laboratory A and B, there are also different number of genes that is on each panel. So that's something to consider when you're sending testing for patients, is what are the genes of interest? And that's really dependent on what your differential diagnosis is and whether those genes that you are concerned about is on the panel. Number two is when we send a cultured skin fibroblast for this gentleman, we got a different result, and this was an unexpected result. They came back with a heterozygous pathogenic 86 kilobase deletion on chromosome 3q, which takes out the entire TERK gene as well as exon 1 of transcript 4 of the MECOM gene. So this was probably the cause of his underlying cytopenias over time, but he really did not get to this diagnosis until it was too late. So for him, we would say to consider what the bone marrow examination trend looks like, and close follow-up is crucial for early diagnosis and monitoring for any clonal evolution. In this case, this is usually consistent with a somatic variant and not a germline variant. Now, in patients with a hematological disorder and an abnormal karyotype on a bone marrow exam, germline genetic testing should be performed on DNA that's extracted from cultured skin fibroblasts or any non-hematopoietic tissue, cultured skin fibroblasts being the gold standard at this point in time. Ancillary tests such as telomere length, chromosomal breakage analysis, and flow cytometry for PNH should be performed early to try and exclude an underlying IBMFS. So for this gentleman, because we had very short telomere lengths, this kind of directed us towards an underlying telomere biology disorder early on when we were initially consulted to see him. The next patient is an older individual. She's a 68-year-old female with a recent diagnosis of myelodysplastic syndrome. However, her history of idiopathic thrombocytopenic purpura began since the age of 28 with an average platelet count in the 60s. Now, she's never been symptomatic and has never required treatment for her thrombocytopenia. She does report, though, a history of lifelong easy bleeding and bruising. And she had a bone marrow biopsy done in 2024, which showed a hypercellular marrow with mild dysplastic changes in the megakaryocytes, but no increase in blasts. Her bone marrow karyotype was normal, 46XX. And here again, we wanted to show and highlight the difference between somatic and germline testing. So she had somatic testing on her bone marrow sample, which was basically a next generation sequencing panel for acute myeloid leukemia and MDS. And what was found was in RUNX1, she had this variant that was at an allele frequency of 50%. Now, anything above 40% makes us a little bit concerned that this could potentially be a germline variant. So she had met the criteria, at least in our institution, for referral for genetic counseling for germline testing, which she consented to, and we sent off DNA extracted from cultured skin fibroblasts that returned with that same heterozygous pathogenic variant in RUNX1. So we confirmed that this RUNX1 variant that we're seeing in the bone marrow is germline in nature. So here she demonstrates that age really is a poor determinator of a germline genetic variant for an underlying inherited bone marrow failure syndrome. In our institution, we use the age of 50 as a cutoff, but again, that's arbitrary. And she demonstrates very clearly that age per se is not a good criteria to use alone if you're trying to decide whether a patient meets the criteria for germline testing or not. Second, a variant allele frequency of greater than 40% on the somatic next generation sequencing panel may indicate the presence of a germline variant, and these patients would qualify for at least a consultation with genetic counseling to determine if they would meet at least even the NCCN guideline for germline testing right now. Certain germline genetic variants have an increased risk of myeloid neoplasms, specifically for myelodysplastic syndrome and/or acute leukemia, and hence should be confirmed on an appropriate non-hematological tissue. So through these 3 patients, we've kind of illustrated the challenges that we see in the adult clinic, where one, the diagnosis may not be straightforward, and this leads to a lot of delays. Second, the prognosis is important to try and understand what the risks of malignancies are and whether there are additional cancer surveillance managements that should be recommended to patients and affected family members. Third, germline genetic testing does have an impact on the clinical management of these patients, especially if they are headed for a bone marrow transplant from a related donor. And if we do detect a germline variant in, say, a sibling who is planned to be the potential donor, then it is very important that the donor is screened for the exact same germline variant to ensure that we do not transplant them with another affected sibling. So the final take-home messages are: 1, an abnormal blood count should always be followed up closely. 2, a detailed personal and generational family history is helpful in identifying individuals who would benefit from additional workup. Third, ancillary testing, including flow cytometry to exclude PNH clones, flow fish for telomere length measurements, and chromosomal breakage analysis, is very important to be performed early, and that will help to guide genetic testing as well as prioritize the most likely diagnosis in these patients. Finally, an early bone marrow examination is important to exclude an underlying malignancy and/or the presence of any somatic variants. Last but not least, we will always recommend early referrals to tertiary hematological centers with multidisciplinary expertise, especially in rare conditions such as inherited bone marrow failure syndromes, because this is crucial for patients to have an accurate diagnosis, but to also have the most appropriate management, not just for themselves, but also for any potential affected family members with the same germline variant. And that's it. Thank you.
Well, thank you very much, Dr. Tung, for such a clear and thought-provoking presentation. I thought the different case studies were really helpful. I'm now delighted to welcome Drs. Keel and Weitz to our virtual panel. Dr. Sioban Keel is Associate Professor in the Division of Hematology and Oncology at the University of Washington School of Medicine. And Dr. Ilene Weitz is Professor of Medicine in the Jane Ann Knoll Division of Hematology at the Keck School of Medicine at the University of Southern California. Before we jump into the Q&A, and please, a reminder, you're welcome to add your questions in the Q&A icon that you should find at the bottom of your screen whenever you like. So you can start putting in questions, and then we'll have a queue ready for the discussion. But before we jump into the Q&A, Dr. Keel wanted to share a few clinical pearls to consider when working up some of the cases that we just discussed, or that Dr. Tung just discussed. And then we'll jump into a Q&A.
Perfect. I just wanted to highlight a few kind of diagnostic clinical pearls that I think we can take away from the really nice illustrative cases that Dr. Tung introduced for us. And so if we kind of look at those cases, the two that I want to highlight are cases number 1 and cases number 2. And so these were hypocellular marrow failure. And I think what's notable about those is they were not what we would classify as non-severe. And so in the clinical setting, we classify the degree of a hypocellular marrow failure in terms of its severity based on how low are the blood counts. And in both of those cases, they would have been called non-severe aplastic anemia. And so if we just kind of step back and talk about that differential diagnosis of hypocellular marrow failure, we broadly classify those as hypocellular marrow failure that's caused by an acquired disorder. And those can be broken down in the diagnoses that I show here. acquired aplastic anemia is caused by an autoimmune attack on the hematopoietic stem and progenitor cells. And it accounts for the majority of cases of patients that present with severe aplastic anemia. And it has a bimodal distribution in terms of its presentation. It can present in young adults and it can present again in the elderly. And alternatively, on the other side, we have the inherited syndromes that we've been talking about here that can also present with a hypocellular marrow. And those I broadly kind of group into the inherited bone marrow failure syndromes, the inherited hematologic malignancy predisposition syndromes, and then more rarely, a group of disorders that are called inborn errors of immunity or the primary immune deficiency syndromes. And I think collectively, if we look at the incidence of these in adults, they underlie about 5 to 15% of adult patients that present with hypocellular marrow failure. And again, I would kind of highlight the individuals that present with less severe disease. So Dr. Tung did a nice job of calling out some of the additional non-sequencing tests that we use in the diagnostic evaluation of our patients that present with hypocellular marrow failure. And I really just wanted to highlight those because they can be quite helpful in the clinic. And those are flow cytometry for a PNH clone, a chromosomal microarray, a chromosomal breakage study, and telomere length testing. And these tests are run all on the peripheral blood apart from the chromosomal microarray, which is available at some centers and is sent on the bone marrow. So when we think about these diagnostic tests, the PNH clone is quite helpful. The PNH clone is detected by flow cytometry, and it's present in about 50% of patients that have acquired aplastic anemia. And in a number of studies that I show here, the presence of a PNH clone is really useful in distinguishing between an acquired aplastic anemia from an inherited cause for the hypocellular marrow failure. And the other thing I just want to highlight is that this testing is most sensitive when it's performed on the peripheral blood as opposed to the bone marrow. And that's just because the GPI-linked proteins that are typically assessed by the assay are most highly expressed on peripheral blood cells. The second test that I wanted to highlight is the second most common somatic genetic. It detects the second most common somatic genetic change that occurs in acquired aplastic anemia. And that's a loss of HLA class 1 alleles that can occur through the loss of one parental HLA haplotype through the acquisition of copy-neutral loss of heterozygosity of chromosome ARM6P, and that involves the HLA locus. This is present in about 10 to 15% of patients that have acquired aplastic anemia and is rare in other contexts. And importantly, diagnostically, its presence has a very high positive predictive value for a diagnosis of acquired aplastic anemia, as opposed to one of the inherited disorders that we've been talking about. The prevailing hypothesis of why this occurs in acquired aplastic anemia is again linked to the autoimmune pathophysiology of the disease. And notably, clinical testing for 6P copy neutral loss of heterozygosity requires a chromosomal microarray analysis. And that can additionally be helpful in the diagnosis of the disorders we are talking about today, because some of those inherited disorders can have copy number aberrations, constitutional copy number aberrations that chromosomal array also can detect. And then the next test that I just wanted to highlight was, given the diagnostic importance of identifying patients with Fanconi anemia, because that really directs treatment and also surveillance, we send at our center a chromosomal breakage test in nearly all patients that present with hypocellular marrow failure. Genetic testing to identify an underlying Fanconi anemia gene follows that testing, but it's not something that can be used to replace the functional assay. And so we still make a diagnosis of Fanconi anemia based on a chromosomal breakage study. And in a small proportion of patients with a clinical diagnosis of Fanconi anemia, chromosomal breakage study may not be increased in the blood, and that's because of a somatic revertant mosaicism, and we have to do it on cultured skin fibroblasts. So the last test I'll just call out, we mentioned earlier, is flow fish to diagnose a short telomere syndrome, to measure the telomere lengths. And again, this is a diagnosis we don't want to miss because it has such important implications on how we treat patients. And this can be measured on a peripheral blood by measuring telomere lengths in both lymphocytes and granulocytes in the peripheral blood. And what I show here is just one example of a flow fish analysis. On the y-axis is lymphocyte telomere lengths, and on the x-axis is age. And each of these downward sloping lines represents the expected telomere lengths for a given age at the 99th percentile, 90th percentile, 50th, 10, and 1%. And what's shown here is telomere lengths in various cohorts of patients. And so what I'll call out first is the telomere lengths in the patients marked by blue circles. Those are patients that have a genetically defined short telomere syndrome. They're all under 40 years of age, and their telomere lengths fall less than the first percentile, which is generally what we expect in this young age group in a person who has a short telomere syndrome. Notably, patients that have acquired aplastic anemia across a pretty broad spectrum of ages, those are the individuals shown here in the blue dots, they have telomere lengths that don't fall within this short range. And then what I'll lastly show is the individuals that are marked by a green dot. Those are individuals that have inherited bone marrow failure syndromes apart from short telomere syndrome, so they're genetically defined. And notably, a few of those individuals do have telomere lengths that land below the first percentile for their age. And so while this testing is very good in detecting a short telomere syndrome in young individuals, it's not entirely specific. And kind of my take-home message for the clinical practice is if you have a telomere length that's above the age-adjusted 50th percentile in the lymphocytes, that's good for excluding a short telomere syndrome. But and an age-adjusted telomere length that falls below the first percentile in individuals that are under 40 years of age, that's pretty strongly supportive of a short telomere syndrome, but not entirely specific. And I'll pause there. I just wanted to highlight those diagnostic tests.
Thanks so much, Dr. Keel. I think those were really helpful. So we're ready to start our Q&A. So please do submit your questions. One question that I had right off the bat was, when do you need to use the gold standard using a skin fibroblast to do your germline testing? And when can you just feel confident that testing on the blood is appropriate? I think I heard, maybe it was you, Dr. Tung, that was saying, well, if the karyotype is okay, then you could go ahead and use the blood. But you could have a normal karyotype and still have, a clonal disease, correct?
Yes, that is true. But I think also trying to get a skin punch biopsy for patients isn't always a straightforward process. It also delays the diagnosis as well because it takes about 2 to 3 weeks to grow those skin fibroblasts. So, and not every center will have that capability to do that. So in those circumstances, I think a lot of providers will err on the side that, well, if the karyotype is normal, we assume that there is no clonal evolution right now and try to do testing on peripheral blood instead. As far as we can, obviously, we would advocate trying to do that on skin fibroblasts, but we understand that there are limitations, so we kind of balancing the time-sensitive aspects of getting a result back that will impact the patient's treatment versus how important it is for us to wait for the skin fibroblasts to send testing from that.
Great, that makes sense. Any further comments?
Yeah, I might just add that kind of pretty commonly in most patients that are being evaluated for MDS or AML, it's generally most individuals have a somatic NGS panel that's done. And so that's standard in upfront diagnostics for an AML or an MDS patient. And I would say if that really shows multiple abnormalities, that'll make the sending of a sample obviously complicated. And so to kind of call that out in those settings where it's time sensitive at our center, we have a person who's been diagnosed with MDS, we got to get them to a transplant. We're trying to figure out, is their sibling a donor? If they're able to achieve remission, so it's an AML patient that goes into remission, a remission sample can be kind of helpful in that setting because it gets around this time-sensitive issue of culturing the skin fibroblasts.
Sure, that all makes sense as well. All right, we have a question that came through on can someone comment on short telomeres below 1% in individuals who are greater than 50, who have bone marrow failure or leukemia or pulmonary fibrosis?
Well, I think that that's something that people don't look at enough. And they see them as separate syndromes. And so you really need to have someone who can pull all that information together and make a diagnosis. Because obviously, as in the second case, it makes a big difference. If the patient already has pulmonary fibrosis, their options for transplant are going to be limited. And whereas the converse may not be true. So if you get them early enough, will it eliminate the risk of pulmonary fibrosis down the line? I don't know the answer to that. And it also depends on what you're going to use for your prep for the bone marrow transplant. So, melphalan's been associated with pulmonary fibrosis. So it gets very complicated to make a decision. And I think that that's part of the difficulty in doing adult patients, because you don't always have all the information. You don't always have the family history. But, that second patient had thrombocytopenia for a really long time. That's not ITP. ITP doesn't present that way. And so I think that kind of chronicity of the cytopenia should have been a tip-off that there's something not correct about the diagnosis. And I had a case sent to me because this was a young man in his early 30s for mild thrombocytopenia, about 60,000. Well, when we took the history, his sister had thrombocytopenia of pregnancy, but was treated with steroids. So that didn't sound right. And then we looked at the patient's hemogram, and his MPV was 14. Now, most people just blow off the MPV, but the MPV can be really helpful in that setting, these enormous platelets. And in fact, he had a Bernard-Soulier variant, as his sister has, as his other sister has, but they all had a range of thrombocytopenia from 60,000 to 130,000. And in fact, he knew that his father had thrombocytopenia, and everybody in the village they came from in Cambodia has mild thrombocytopenia. So, you have to dig into the history. We couldn't get the father to come in. He didn't want to be tested. But, that's why it's so hard in adults to make the diagnosis.
I might add also just the kind of converse of what the question was. So the question here was, gosh, what about a telomere length that was less than the first percentile in an individual over 40? I wanted to just highlight that if you look at telomere length testing in individuals that are over 40, that land between the first and 10th percentile. So if you take all individuals over 40 that have a genetically confirmed short telomere syndrome, about 50% of them will have telomere lengths that are between the 1st and 10th percentile rather than that very short telomere length. And so I think one of the complexities that really hits us is less so interpreting the very short telomeres, it's the telomere lengths that fall in that 1st to 10th percentile in an adult population. And that's
Can you
further.
repeat that again? You're saying that they have a confirmed short telomere syndrome, and yet at older age, you see the telomeres actually between 1 and 10%.
Exactly. So the diagnostic kind of specificity or the utility of that sensitivity diagnostically in older individuals is more complex because the telomere lengths aren't markedly shorter. So let me say it a different way so it's clear. Sorry guys. If you think about short telomere syndromes, the presentation, their phenotypes, is a function of the degree of their telomere length shortening. And so individuals, we use the term that present as little kids with an obvious syndromic presentation, the term dyskeratosis congenita is what's used. And those individuals have markedly short telomere length, and they present with a much more prominent clinical phenotype at a young age, bone marrow failure, congenital malformations. The most common presentation in an adult is a presentation of lung disease, and the telomere length shortening is not as severe.
Mm-hmm.
And so that phenotype is a function of the fact that the telomere length isn't as short as the little one who presents with more severe disease. I hope I said that clearly.
Yeah, no, that makes sense. That makes a lot of sense the way you just.
I think the other thing is that, in the first case, I thought it was really fascinating that the patient had hearing loss. And a lot of these congenital syndromes are associated with hearing loss. NYH9 disorders of platelets associated with hearing loss and kidney disease. And, unfortunately, the providers on the outside don't always put those things together.
Mm-hmm.
And so educating the house staff and the physicians is really important because they may miss these, putting these things together.
Or even asking the question, right? To
Right,
get
and
out
then
of the
doing the
patient.
testing that should be required.
Right. Yeah, thank you for that comment. We have a nice comment from someone that says, thanks for the wonderful talks. Just to compliment, there's a very nice paper published in Blood 2023, Differential Diagnosis of Bone Marrow Failure Syndromes Guided by Machine Learning by Fernanda Gutierrez Rodriguez, showing how to use clinical and laboratory tests in helping diagnosing, I think, constitutional acquired bone marrow failure syndrome. So we can maybe send that paper out or that link after the webinar. I haven't read it, but have maybe all of you have seen it. Great. So that sounds like that could be a valuable tool or resource. There was another comment, and I don't know if all of you have an answer to it, but the comment was, are there any more labs that are offering testing for hereditary heme malignancy conditions or bone marrow failure syndromes? Our team has found it very challenging to find a lab that will A, culture fibroblasts, B, test for the genes that are appropriate, and C, be at a reasonable out-of-pocket cost for the patient. We advocate with our lab reps, but it seems there's no concerted effort to increase access for patients to this testing. Any other any ideas there? Do you know if there's any help?
I would say that I'm kind of very privileged here at Iowa because we work with the cytogenetics lab very closely. They are within our same division and just down the corridor. So they have been really good at helping us doing the cultured skin fibroblasts. I didn't realize until I spoke to other people that that's not a given in many places. And it's hard to find a lab that will culture skin fibroblasts for you. I think there are probably 1 or 2 commercial labs that can do it for a fee. But again, the panels that they put together for bone marrow failure syndromes or even germline predisposition to hematological malignancies is very varied from company to company. So it's hard, but I think as the team start to do more testing, because we have a working group that's been doing this for almost 2 years now. And we are trying to put out a paper about our experience with that as well, because we understand that there are so many different pieces in terms of the logistics of getting it done, that can be very complicated. There are obviously some labs that we prefer using because it's kind of more patient friendly in terms of out-of-pocket costs should insurance not cover it. But then that's also a scenario that's kind of changing as we speak. I know there are other labs that does a lot more cancer genetic testing, and they are starting to go into that heme malignancy space. They're very good for solid tumors, and they know, like, one of our genetic counselors here left to go work for this company, and she was like, hey, you know, we need to look at patients with heme malignancies, and they're starting to kind of try to come into that space with the different test options as well.
Well, that's very good to hear. And we have actually a comment from one of the attendees that says, the only commercial lab I have found that's great is GeneDx, and they offer $550 self-pay pricing and will culture fibroblasts. And then this person also mentions University of Chicago as a comprehensive testing resource, and they too will do fibroblasts. And not that we're here to promote any one commercial lab or group, but just sharing what people have shared in the Q&A. There was a quick question, and I think the answer was a DKC-VUS, but the question is, what mutation was identified in case number 1? I missed the first case.
Yeah, so that's in the DKC1 gene, but it was kind of categorized as a VUS because, again, this patient resides outside of the US and is from an ethnic group that is not well represented. It's a minority ethnicity, so it's not well represented in the population database. So that's kind of probably the main reason why it was a VUS. We are kind of still trying to work through his splicing variant to try and determine the pathogenicity of it, but given his history and his clinical presentation, it's likely that this would be over time upgraded to a likely pathogenic variant.
And that's how you ended up treating or managing the patient, right? As though it was.
Yes.
There's another question regarding a telomere length measurement again. One, if there is suspicion of a telomere biology disorder, would you send a telomere length measurement and genetic testing at the same time? Or would you do telomere length measurement after a negative genetic testing? If genetic testing is positive, would you still send telomere length measurements? Maybe we'll start there and then we can do the second one.
I can share maybe what we do at our,
Sure.
and I think there is kind of differences in practice. So this is just our approach. If a person presents with a non-severe aplastic anemia, so that there is not an urgency to make a diagnosis, they're not going to transplant, I think you have more flexibility in timing of things. And so I'll say that up front. And so in all our patients that present with hypocellular marrow failure, whether it's severe or non-severe, we currently are sending a chromosome fragility analysis, a peripheral blood PNH, and we send a telomere length testing on the peripheral blood. And if in a severe patient, there's a PNH clone positive, we're not routinely sending genetic testing on those individuals for a germline disorder.
Thank you. Anything else that you would want to add, Dr. Tung, Dr. Weitz?
No, I mean, I think that's pretty reasonable. I mean, and having a PNH clone really indicates a different pathology. And most of these are really tiny clones, and we just follow them. We don't do anything about them. They don't warrant treatment, but they're a very good marker for a different process. So if they have a genetic predisposition, that's a whole other issue. But in general, we don't proceed past that.
Okay.
And I guess I would share what we do in our institutions. Mainly the consults that we get are for patients with high-grade MDS or even acute myeloid leukemia who's requiring treatment. One of the things that we found is trying to send off telomere lengths. In that setting, their white counts are too low. So we haven't been very successful in trying to send telomere lengths when they are at the stage where they need chemotherapy and they will probably be considered for transplant. So ideally, you want to move that time frame much earlier on when they're non-severe pancytopenia, so that you actually have decent white cell count to send out the telomere lengths. So that's been one of the challenge with the high-grade MDS and AML group that's the bulk of what we see. We don't get a lot of referrals for aplastic anemia at this stage, but that is something they're working with to try and maybe consider seeing them at the earlier phase, so that we could potentially try to tease that out a little bit more. I do know that both the pediatric and adult hematologists in our center do send all the ancillary tests as part of their protocol and workup for someone with pancytopenia.
Great, thanks, Dr. Tung. The other part of this person's question was around, it was a question about the fact that some papers, some studies are reporting that short telomeres suggesting that short telomere is a heritable trait independent of a pathogenic variant in a telomere biology disorder gene. And if the first degree relative of a proband having positive genetic testing and a short telomere is tested negative for the familial variant, would you suggest checking the telomere length in that family member?
Oh, I like that question.
Yeah,
Maybe I'll take.
sure. Yeah, how would you approach it?
And so I'm smiling because sometimes that term. So let me just phrase what I think the person is asking is, if a person has a short telomere syndrome and passes that on to their child, they could or it has a short telomere syndrome and then has a child, they can pass on the telomere length that they're starting with in their germ cells, which would be short because they have a short telomere syndrome, and or the genetic change that caused that short telomere. So you could imagine that you could pass on both of those, or you could pass on one or the other of those. And passing on the starting with a shorter telomere length, passing that on and not the actual genetic variant. Sometimes the phrase that people use is a teletype to describe that. And I'm smiling because I always think of Teletubbies when I think about teletypes. But I'm not aware, and maybe Dr. Weitz or Dr. Tung can jump in here. I'm not aware of the teletype across successive generations. So the other kind of genetic characteristic of short telomere syndromes is something called genetic anticipation. Because of that teletype, that in subsequent generations, you can pass on a shorter telomere length so that in the next generation, the presentation in the individual could be earlier and with a more severe phenotype. I'm not aware of that manifesting just straight as the teletype without the genetic change in persons across generations. I know that it's been described in mouse models of short telomeres, but I don't know if that's been described in a person before. Dr. Weitz or Dr. Tung, do you know?
Yeah, I'm not really aware of that. But, I mean, things like, I know this will sound really silly, but things like early graying, okay, which are associated with short telomeres. Does that mean that you're going to have a short telomere syndrome down the road? You know what I'm saying?
Mm-hmm.
It doesn't confer the disorder on you. So, as someone who has grayed very early, but and it's a family trait, and my kids have it, but everybody lived forever in our family, so it doesn't confer pathology.
Mm-hmm.
You know what I'm saying?
And then maybe I'll just, so I think the questioner was also asking, well, gosh, if you have that in a family, how do you test the other individuals? Let's say we identify the proband in a family with a short telomere syndrome. What are we doing to test other family members for a short telomere? I think that's also, there aren't standards around what family members should have testing. And I do think that's very much an individual decision for family members. And that's for a few reasons. The presentation in adults, for example, is still a presentation in adults, that the interstitial lung disease occurs maybe about 10 years younger than idiopathic pulmonary fibrosis that occurs outside of a short telomere syndrome. But it's unusual to present in a person under 40 when the proband presented as an adult with interstitial lung disease. And so I'm thoughtful about a young family member when their parent may have presented with pulmonary fibrosis at 60 and saying, hey, should we do something? Should we test you? Should we measure your telomere lengths, or should we send genetic testing? Because that individual is unlikely, even if they have the genetic disorder. One, there's variable penetrance, and two, the age of onset is still expected to be in an adult setting. So I've generally not sent testing on younger individuals when the proband presented as an adult with the short telomere syndrome.
When you, Dr. Keel, can you just clarify, when you say younger, are you talking below, under age of 18?
I would say under age 40.
Oh, wow.
Yeah, and I have a pretty long discussion with the patients around that. And I don't know, I mean, Dr. Tung or Dr. Weitz, you may jump in there. I'm just very thoughtful about what are we going to do here. And one of the reasons I say that is some of the things that we recommend for these patients: don't smoke, wear sunscreen. Those are lots of health, kind of positive health things that we can recommend independent of having that. And I also think in the context of a family history of pulmonary fibrosis, one might want to make those decisions anyways without knowing their telomere length or their genetic status. And we don't have a therapeutic intervention at this juncture that lengthens individuals' telomere length. So I do think it's a really individualized decision if folks want to do that. And I have had folks under 40 want to have testing, and we just have a long discussion about it. What do we know? What don't we know? And come up with shared decision making.
Yeah, and I think that's kind of why I feel very strongly that a lot more research in this space is needed to collect the data over time, because I see the two extremes. I'm seeing 70 years old with pulmonary fibrosis. I just saw one lady yesterday and she said, well, mom, my brother, my sister all had pulmonary fibrosis and died in their 70s with this. Can I be tested? Right? Because she has pulmonary fibrosis. And I said, well, we have that long conversation. But on the other hand, I'm also getting referrals for a lot of children with, say, multiple congenital anomalies. They have a whole exome sequencing done, and then they find a variant in the TBD gene, but they're not symptomatic yet, right? Do you do telomere lengths for them? When their CBC count is normal, they don't have any relevant history from that point, because my youngest kid is like 2, but he was diagnosed really at the age of 1 when he had an exome sequencing and found a change in the TBD gene. So I think the conversation that I have with my patients really in the clinic is, one, having a genetic change doesn't always predict when and how you will get disease, whether is it going to be a bone marrow failure, whether it's going to be pulmonary, whether it's a combination of different organs involvement, because it's a risk, but as of now, we cannot predict because of the variable penetrance that we see in the different families. So it is a difficult conversation, but like what Dr. Keel says is, you tell them what you know, what we know right now, what we don't know, which is probably a lot more than what we do know. And because there's no treatment, the question that we have is, what kind of surveillance would we recommend, right? The protective health behaviors like not smoking, not drinking, doing all your cancer screening, that does not change regardless of whether your telomeres are short or long, or you have a genetic change. We would still recommend those proactive things to do overall anyway. So we have that conversation and then we talk about specifics. Now, one of the things that we can say is, well, if they feel very worried, because there are some families who say, well, I have multiple individuals in my family with bone marrow failure or MDS, they are so worried that they ask for CBC. And I think that's an easy enough screening test to do, and the PCP can do that as well, right? So I think there are some of these easier things that can be done in a primary care setting, and when things like that change, then they get referred to a tertiary hospital to kind of like get the full workup done to see where they are. That being said, we also have a TBD family that was really one of the first cases that was reported by Dr. Goldman in literature with the autosomal dominant form of DKC1. Now, come a full circle presenting with acute myeloid leukemia after almost 20 years. So I think the longitudinal natural history is important because we don't really know how different individuals will behave over time.
Yeah,
Absolutely.
and then I just wanted to clarify, you guys, I'm talking about in a family where the proband presents as an adult with pulmonary fibrosis. That's a very different genetic disorder than a family that presents with dyskeratosis in a little one. Those are different genetic variants typically, and the telomere length is very different in those settings. So that's a different natural, that's a different counseling with the patient and the family.
Yeah, which you showed us in that graph, the very, very much below the first percentile. So thank you for the clarification.
Dr. Tung had an important point. The issue is, what are you going to do with that information? And is there any treatment that can prevent progression? Or are we just going to follow the patient? And I don't know the answer to that. I mean, I think it's a real dilemma. And patients want to know, but we can't really tell them that they're going to progress to pulmonary fibrosis versus AML. It sort of depends on what the family history has demonstrated. And if there are multiple people with pulmonary fibrosis, likely that's going to contribute. That's going to be where they're headed, but you can't predict that.
Right, right. I mean, hopefully the conversation demonstrates to the patient that the most important thing is to stay on top of your health and stay on top of, your regular screenings.
Don't do the things that will make it worse.
Right, right. Don't do the things that, and of course I always say, like, it's, while there may not be a treatment today, there could be a treatment tomorrow. And there's ongoing research. So, not to lose sight of hope that, that doesn't just mean that you're going to have a bad outcome. There's some other really good questions, but I realize we're already 9 minutes over. There is one question I do want to address, which was something at the last question that came in regarding research on really helping to classify variants of unknown significance to likely pathogenic and pathogenic. There's a lot of effort there, and there's a whole there's ClinVar. Hopefully you've heard of ClinVar. If you're a practitioner and you come across a VUS, please submit that into ClinVar. It's a government-run data set, and then you can put in, medical family history, medical, clinical phenotypes, and that will help with reclassifying VUSs over time. There's groups that are expert groups that go in and review ClinVar and then try to help move a VUS either to a benign or a pathogenic score. So there's a lot of research, and we can send a link out about ClinVar after this as well. Thank you, Dr. Tung, Keel, and Weitz for being here with us. This was a really valuable conversation. Unfortunately, we didn't get through all the questions, but maybe if there's some we can get to after and send out an email, we can do that. And I hope you all have a great rest of your day.